You're listening to a podcast of the World Stroke Academy, the educational platform of the World Stroke Organization. Future Stroke Leaders is an initiative of the WSO to develop the technical and research skills of the next generation of stroke professionals. The World Stroke Academy welcomed the contribution of the Future Stroke Leaders members by inviting them to cover specific stroke-related topics in our Pearls Podcast initiative.
Hello there and welcome to the World Stroke Academy Pearls Podcast series. My name is Laetitia Yperzeele and I'm a stroke neurologist working at the Antwerp University Hospital in Belgium and at the Faculty of Medicine and Health Sciences of the University of Antwerp as an assistant professor. I'm also very proud to be a member of the first cohort of the Future Stroke Leaders program of the World Stroke Organization. Today, I want to discuss a clinical challenge that many of you will already have faced. It's the one of the patient presenting at the emergency department with an acute onset of dizziness or vertigo. This is a very common reason for presentation at the ED, making up 4% of all consults there. Now, why is this so challenging? Well, we know that 95% of these patients are not having a stroke, but we certainly do not want to miss those who are. But the thing is, we do. We miss them quite often even. Misdiagnosis of posterior fossa stroke is common, and many of us working in acute stroke care will probably already have missed a few posterior circulation strokes in their careers. And I can speak for myself. I have failed to recognize patients presenting with posterior fossa stroke at first contact in the ED. Numbers in the literature may vary, but it is estimated that 10 to 30% of stroke patients presenting with dizziness are initially missed, and that the numbers are even higher for patients with transient symptoms due to posterior fossa TIA. Studies have shown that misdiagnosis appears more often in young patients, women and minorities, with their symptoms being attributed to another cause than stroke at first contact. And of course, misdiagnosis can lead to delayed or missed treatment opportunities like recanalization therapies, early initiation of secondary prevention or surgical treatment. And failure to identify stroke early can therefore result in worse outcome. This said, on the other hand, we do not want to overtest patients with acute dizziness from other causes like peripheral vestibular pathology, because this results in unnecessary costs, for example, for brain imaging and hospital admissions. So, it's clear we need a structured and standardized diagnostic approach for these patients, and the way to move forward with this is to focus on symptom characteristics, red flags, and bedside clinical examination, looking for clues that reveal central pathology. It has been confirmed in several studies that an approach that combines symptom features with vestibular, oculomotor and balance examination has the highest diagnostic sensitivity to differentiate between central and peripheral vestibular disorders. So, how should we approach a patient presenting with acute onset of dizziness or vertigo? The traditional approach, and I believe many of us were still taught this approach in medical school, was to focus on defining the type of dizziness. Does a patient feel unstable on his feet? Is he lightheaded? Or is there a sensation of rotational movement, etc., etc.? In this approach, the so-called true vertigo was considered to be suggestive of peripheral vestibular pathology, and other types of dizziness to be more frequently associated with other conditions like neurological disease, including stroke, cardiovascular problems such as pre-syncope, or metabolic conditions. However, a national US health interview survey performed in 2008 indicated that there is only little correlation between the type of dizziness and the cause. Patients with suspected peripheral vestibular disorders only complained about pure vertigo in a quarter of cases, with reports of different types of dizziness in the remaining 3/4. So, if defining the type of dizziness has only limited value, a different approach is clearly required. An alternative assessment was described by Tehrani et al. In their publication in Stroke in 2018, which was called the titrate algorithm. In this paper, the authors proposed to classify acute vertigo or dizziness first by its timing and trigger, and then to use targeted bedside eye movement examinations to differentiate between peripheral and central causes. The authors then continued to describe 4 different syndromes based on the onset, duration, and evolution of the dizziness and actions, movements, or situations that provoke the onset of symptoms. Acute and spontaneous symptom onset of either transient, in the case of posterior fossa TIA, or persistent, in the case of posterior fossa stroke, are important red flags. In the bedside clinical evaluation of patients with acute onset spontaneous dizziness, a 3-part bedside oculomotor examination called HINTS is used. H and I stand for Head Impulse Test or Halmagyi test. N and T stand for assessment of the nystagmus type, in which a multidirectional, vertical, or dissociated nystagmus is suggestive of a central cause. And the S finally stands for assessment of skew deviation. And for this assessment, one can use the alternate eye cover test. Finding a bilaterally normal head impulse test in the presence of spontaneous nystagmus is a red flag and is highly suggestive of a central lesion. One can improve sensitivity even more by adding assessment for acute hearing loss using finger rubbing, and this is then called the HINTS Plus. It is important to note that HINTS should be used only for patients with acute onset spontaneous dizziness, but not in patients with symptoms caused by specific actions, movements, or situations that can provoke the symptoms. In patients with this triggered type of vertigo, the Dix-Hallpike examination is used to search for the typical positional nystagmus suggestive of BPPV. Besides these targeted assessments, the bedside examination, of course, should also include the assessment of vitals, glycemia, and a full neurological examination to look for other symptoms suggestive of stroke. These can include Horner syndrome or the presence of lateralized motor symptoms or limb dysmetria, but also the presence of severe gait disorder, where patients are unable to walk even when they are supported. The presence of dysarthria or dysphagia are considered red flags suggesting stroke as a cause of dizziness. Other red flags include the presence of headache, especially if it's severe or if it had an acute onset, and the presence of hearing loss, which can be suggestive of anterior inferior cerebral artery ischemia and is present in about 50% of cases when ischemia occurs at this location. If you want to learn more about the features of posterior fossa strokes, I strongly suggest you to watch the lecture of Professor Patrick Michel, which he gave for the World Stroke Academy about this topic. It's an amazing lecture with a very practical approach, and the link can be found on the WSA webpage or directly on YouTube. If red flags arise from the clinical examination, diagnostic imaging is of course indicated. And although CT scans are often used in patients presenting to the ED with dizziness, their sensitivity for the identification of acute ischemic strokes is extremely low, especially in the posterior fossa. CT scans are only considered to be useful when screening patients with isolated dizziness who are at high risk of acute intracranial hemorrhage, such as in the case of metastatic melanoma. And this is because cerebellar hemorrhage only very rarely presents with isolated dizziness in the absence of other clear central neurological deficits. Of course, CT scan should be performed in patients considered for treatment with IV thrombolysis, or in the case of high suspicion of vertebral artery dissection, in which CT angiography should be performed. But the key message here is that if you need neuroimaging, it's recommended to use MRI. However, keep in mind that early diffusion weight imaging can miss up to 20% of acute posterior fossa infarcts, and probably even more when the strokes are small. Therefore, it has been suggested to perform MRI only 3 to 4 days after symptom onset. Additionally, specific MRI protocols with thinner slides of the posterior fossa can be useful. Although assessing patients with acute dizziness may be challenging, using a systematic approach brings you a long way in identifying patients with potential stroke. I hope you've enjoyed listening to this podcast. Let's end by summarizing the main take-home messages. The first one is perform a structured clinical assessment. By performing a head impulse test assessment of nystagmus type and by screening for skew deviation, in combination with a search for additional neurological symptoms and red flags, you can rule out stroke with a higher sensitivity than early MRI. When the assessment is negative, you can refrain from additional workup with confidence. Use the HINTS approach for patients with acute onset spontaneous dizziness, but not for patients with triggered vertigo, for which you should use the Dix-Hallpike maneuver. Second, look for these red flags. There are several red flags that should point you in the direction of posterior fossa stroke as a cause of dizziness or vertigo. And these are the acute and spontaneous onset of symptoms, severe problems with walking even when the patient is supported, the association of acute hearing loss or acute onset of headache, the presence of vascular risk factors or other neurological symptoms. Third, choose your imaging wisely. Use the CT scan only for the right indications, as it can falsely reassure you when negative. In case of clinical clues for central pathology or the presence of red flags, you should use MRI scan with thin slices, preferably 3 to 4 days after symptom onset. So, I hope this overview has helped you to approach patients with acute dizziness with more confidence in your clinical assessment, and that it will help you to identify those in need of additional imaging while avoiding unnecessary workup and admission in those who do not. Before ending this recording, I would like to thank Professor Vincent van Rompuy from the ENT department of the Antwerp University Hospital for revising the content of this podcast. It's been a pleasure to be here on the World Stroke Academy podcast, and I hope to talk to you again soon.
Thank you for listening to this podcast. You can find additional stroke education material and resources in our World Stroke Academy website and social media channels.